You've been treating back pain for a long time. What is something you would never do?
Something I would never do? Oh.
Epidurals, not FDA approved for spine use. Have you heard this? Have you seen this? I assume you have. Why are people out there saying, oh, this is not approved for the spine?
So, for example, arthritis on the back joints, right? It's going to happen for everybody, and it may not cause pain. Just because you have arthritis on the back joints doesn't necessarily mean that you need to have something done about it.
Welcome back to What Can We Get Into? We got a familiar face today, Dr. Eric Anderson. He was one of my first guests, had a couple topics go viral talking to the people about MRIs, but welcome back, Dr. Anderson.
Thank you. Good to be back.
Of course.
Excited to talk today.
Of course. So we want to talk about, some of the same topics we talked about last time, but we also want to expand upon what we talked about last time. And before we started this podcast, we were talking about some of the new procedures and treatment styles that you are getting into these days. So one thing that we just got done talking about and that I want to get on the record here is something called anterior column pain. So break that down for the people here.
Yeah, anterior column pain, simply put, is pain that comes from or emanates from the front of the spine. And if you break the spine down to basically the front of the spine, the back of the spine, the front of the spine is where the little discs are, little shock absorbers in between the vertebral bodies, and the vertebral bodies are on top of those discs. And so pain coming from there, we've always known historically that pain comes from those areas. Those can be pain-generating sites. What we haven't developed very well is treatment options for that. We used to always kind of joke, like if you could find a way to effectively treat discogenic pain, it's somewhat the Shangri-La of pain management, right? Because historically, and you probably know this and maybe your viewers do as well, but the disc initially doesn't have any innervation at all.
Correct.
It's locked in with a little tough ring on the outside called the annulus fibrosus, and it never gets exposed to the human body. It's, when we're tiny little fetuses, there's a little tiny notochord, and it locks it off from the immune system. And that can serve a very helpful function when there is an event that occurs in that disc, such as a disc herniation, or like the disc is jelly coming out of a jelly donut is sort of how I describe that. And it creates a really strong, robust inflammatory response, and people will describe it as some of the worst, usually leg pain they may have ever experienced before. After there's an insult to that disc, as a response to heal that disc, blood comes into that area, and it's already gets a low blood supply in general. But now as a blood supply comes in to heal that area, the blood vessels bring with it innervation. So those discs become innervated. They weren't innervated before. And now you can have a pain coming from those discs that can be long-standing.
Interesting. You know what? It's you taught me a couple of things there, which is, I always thought that there was some nerve endings there, but you're saying that because of an insult to that, blood flow and then nerve endings? There's some nerve endings there. We talk about like the vertebral body nerve that innervates that area, but it's not designed to be necessarily a pain transmitter. Okay.
And so then those nerves proliferate and create sort of a loop of transmission that usually ends up being for pain purposes.
Interesting. So someone has this type of pain. What are you going to do about it?
So we need to first diagnose it,
okay?
Because as you know, there can be 5 to 8 different things in the back that can cause the back pain.
Sure.
So if we have a high suspicion based on the history, the physical exam, usually we complement this with imaging. We would do usually a test block of that disc first, and that's just done in the office setting with x-ray. We usually do it with a little bit of sedation for comfort reasons. And we put a small needle into the disc, inject a little bit of dye to confirm we're in the disc appropriately, and then we inject just a little bit of steroid and numbing medicine. We also note the morphology of the disc and how it looks to see if it looks like it's completely degenerated or not. And then we take everything out, have them wake up in recovery, and see if there's any change in their back pain. Now we know the certain discs we think are the ones causing the pain are now numbed up, so to speak. And depending on their response to that, they may benefit from a treatment option where we can inject actually cadaveric disc particles into that disc to help restore some of that disc function.
So would that can be considered more of a regenerative treatment to the disc?
I wouldn't classify it as regenerative medicine per se, but in the sense that it kind of restores disc. Semantically it would be, yeah.
How long have you been doing this type of procedure?
We've been doing this for several years now. We really picked up on it here this year, speaking with some of the other leaders in the field, and they were saying, man, the disc is just, one of our colleagues who's very prominent in the field, he told us at a conference, he's like, if you start treating this disc for patients, it will change your life. Not just their life, because you're going to have such an impact on these patients that goes untreated. And so we're like, whoa, coming from this guy, this is pretty important.
What's interesting is making that diagnosis is the hardest part. Are you seeing anything on an MRI in terms of desiccation or anything like that tips you off to where you maybe want to be? What do you go off of dermatome symptoms, weakness? What do you go off of initially without laying any hands on a patient?
Good question. Yeah. So typically we'll look at the MRI and we'll note usually the most degenerative levels. And usually we're going to see that at 3, 4, 4, 5, and 5, 1. Typically, sometimes it's higher than that, but that's where all the wear and tear occurs. And so usually those are going to be the levels that we'll target. We have done some where there's a little higher than that based on imaging, but then we'll complement that with an exam to see if there might have some discogenic pain generators in that scenario.
So we mentioned how this is not technically regenerative medicine. What is your opinion on stem cells and PRP and things of that nature in the spine, or in and around the spine?
So that is a pretty hot topic right now because I think everybody recognizes the amount of potential that could come from a regenerative therapy that's effective in the spine, and everybody would want a treatment for that if it's possible. I was just at a conference last week, actually, and I was on a panel with one of the guys that does the most research in stem cells in our pain management space, Dr. Candido, and he's done a lot of studies looking at PRP and stem cells specifically in the spine. And he said it can be very effective. I asked him specifically about this. And it's going to be very effective. The studies he's doing aren't in the United States because we can't really do studies on this type of stuff on patients in the United States. But he's like, we're still kind of tweaking out, doses, frequencies, quantities. There's definitely something there, but we haven't gotten all the way there yet to say, hey, you have this going on. Let's give you, 2 or 3 stem cell injections. That being said, there are a lot of people out there doing that with great results, but that's in terms of what I know of the data right now in regenerative medicine.
I have a colleague of mine, friend of mine that does this type of thing. And I would say that for the most part, my anecdotal experience from patients is they spend a lot of money on this type of stuff and it doesn't work well. I've noticed that PRP works better with tendinopathies, extremities, wrists, elbows, knees, things like that. I haven't heard too much of that being beneficial in the spine. Have you anecdotally with patients have had anybody that sought this treatment and was like, holy cow, this is a miracle?
Anecdotally, I have not had anybody say, hey, I had a PRP, injection in my spine and it did wonders. In terms of other colleagues in the pain space that have done it, they are saying they get some good results. But I kind of agree with you that we don't offer stem cells right now. We do offer PRP. We don't offer it to everybody. We do mention it on our website, but I agree with you. The real and because it's data driven, if we're going to offer this to patients, first of all, it's not covered by insurance. Essentially universally, it's not cheap. And so if we're going to offer this, we really want it to be for a condition that we think is going to provide the outcome, have the highest chance of providing the outcome. And so, we don't do a ton of these, but it's going to be the same things you mentioned, like joint injections, shoulders, knees, tendinopathies. That seems to be where there's really good, consistent data on
How
PRP.
do you feel about peptides?
I don't know a ton about them. I've had patients that have been getting them and singing their praises. In fact, I just signed up for a webinar on them. And I think it's coming up in the next week or two. And I want to know more about them because my knowledge on them is not where it should be with what I'm hearing about them.
I did a podcast with the colleague that I was telling you about. Glenn Cochran is his name. He has an office here in Fort Worth called Infinity Functional Performance, I believe is the name of it. And when I had him on the podcast, I kept trying to steer him of what's best for the spine, what's best for rotator cuff tear, what's best for plantar fasciitis. And the approach that he takes is almost every injection he does is a cocktail, right? He's not doing just stem cells for the spine. He's not doing just PRP for a tendinopathy. He's doing this sort of concoction, which I thought was interesting. I haven't heard that type of thing before, which when you're talking about price, you're going to 3x the price that you already thought was expensive when you just take that approach. But it was interesting to hear him talk about that, because I was trying to go, what's best for this? What's best for this? Try to get a clear correlation. And he was kind of like, open the floodgates on it.
And it might be hard if there's not a lot of data on that yet. They're probably teasing that out. And I'm sure he's wanting to get an outcome for his patients too. And so maybe he's finding that we can kind of cover all of our bases potentially,
Do you think that there's an ethical way that they can harvest stem cells when this becomes more of a researched and more accepted practice, or there's data that supports it?
I do. I think there's a big future in that if it gets figured out kind of the right way, for the right reasons, and for the right conditions. We've been injecting. I was an anesthesia resident, and we do the cardiothoracic rotation. Those are always big rotations. They're big cases. Crack the chest open, do bypass, or repair valves and things. And this was 15 years ago now, and we would inject 100 cc's of PRP in all those patients beforehand, just for helping with the healing and the
really,
yeah. And we didn't think much about it back then. It was just something the surgeon was like, let's get the inject the PRPs, and let's get them circulating.
How does PRP help? Like when you were doing that, what was the thought process? Was it just to stimulate the healing process?
Yeah, I think part of it was there's going to be a very robust inflammatory response from this huge trauma that's occurring on the body. That's going to require a lot of healing. You crack open the sternum, you spread it out, and now you're stopping the heart in most cases, putting them on a pump that's actually keeping them alive and oxygenating their body. And so once you close everything up, the body's just like in total chaos with inflammation and stress. And so the thought was it's going to help kind of calm that down.
Interesting. I want to switch gears. Ketamine therapy. This is something that I didn't think that was done in doctors' offices, to be honest with you, until about 18 months ago. And I've had a few patients that have gone through this with good results. This is something you do in your office, correct?
We do ketamine, yeah.
So talk to me about this. Educate me on this. For quite frankly, I don't necessarily know the physiology of how this works and how you would prescribe it.
Yeah, just give some background. And ketamine is very prominent in the last 5 to 10 years, so most people might know about it. But ketamine is classified as an anesthetic agent, so it's used to put people to sleep. It's one of about 4 induction agents that you can use to put people to sleep initially. It works primarily in terms from a pain perspective, on a receptor called the NMDA receptor, which is different than opioid receptors and some other pain receptors. And the thought process is that it actually activates that receptor and kind of downregulates some of the opioid receptors, and because of that, has its own pain benefit. Now, in terms of what conditions is it good for, the best data is actually for depression.
Interesting.
That seems to be the best data. There's something about kind of resetting those receptors in the brain. It doesn't seem to be quite as effective as something like ECT, which has been electroconvulsive therapy, which has been around for almost over 60 years now, and is kind of barbaric in some regards, but very effective. So, but from a pain perspective, I actually did my grand rounds on this because I was very interested in it, and again, we're having some of the same challenges with ketamine that we have with, say, stem cells. It's going to be, what's the dose? What's the frequency? How long do we expect it to work for? And what conditions does it seem to work for? Is it a panacea for all chronic pain? And it's definitely not. It seems to work best for very neuropathic conditions, so nervous system related conditions that usually are resistant to other treatment options for pain. And in terms of duration and effect, there seems to be a good pattern with rapid short-term doses, kind of relatively high doses for maybe 1 or maybe 2 to 5 days in a row. If you can do more days, you typically get a longer effect. But for chronic pain syndromes or CRPS, another condition we can talk about, which was seen in our patient population frequently, we seem to see a duration of relief, depending on those parameters, maybe 12 weeks, sometimes longer. Now, we don't recommend this treatment to everybody as an initial line therapy. It ends up being kind of down with PRP, where it's a sort of end stage. We've tried a lot of the traditional options, And we are at a place now where we don't know what else to really do for you, and so let's try that. So we do have a few patients in the practice that come in, and we'll get those in infusions.
I was thinking that you were going to say this was more of a microdosing situation versus a big bolus a couple times.
So what is microdosing versus what is a bolus, and so an induction dose, not to put you to sleep, is going to be like a milligram per kilogram. So you're talking like if you're 200 pounds, 1 milligram per kilogram puts you at about 100 milligrams. Like boom, that's really high. You're gonna, because it has some psychogenic properties. You can have hallucinations, and they're usually not good hallucinations.
I was going to say, are people having like pretty crazy side effects with this, I assume, because of that?
So you want to titrate the infusion and the dose to just before you're getting bad side effects. And the patients will be aware of that. They'll say, I'm feeling, initially they'll feel kind of weird. And then if it gets to be a little too high, they'll be like, I don't feel right. This is getting to be too much, or, it's not enough. And so we can augment that with some other medications to help decrease that if we're trying to get to a higher dose, or we back off the dose and maybe run the infusion a little longer if we need to.
It's interesting. What do you think the future of that is? Just honing in on the dosage, or what do you think the future is of that?
It's challenging. There's some new brand name ketamine intranasals out, and some orals and stuff, and that seem to be, I think Spravato is one of them, and they seem to be having some good long-term effects. We do have a couple patients that do take that. Obviously, the risk now, what was that, about a year ago, Matthew Perry had overdosed on ketamine. So it ends up always being like a balance between, what's safe and effective, and then, what puts people at risk, and, how can we mitigate that? So I think for the right patient, the right condition, in the right hands for the right reason, it can work really well. But just like with most pain treatments, you got to have the right patient and the right condition that you're treating to have an effective outcome.
We spoke about opiates before. Do you think there's ever a justification for long-term chronic opiate use? Yes. What do you think that justification is in current waters with treatments that are available to you and to me and the rest of the medical field?
So our approach, which I think is the right approach, is that opioids are indicated, but it's usually going to be a last line agent.
Sure.
Usually not a first line agent. So how we would explain it, we have 4 or 5 different modalities we're going to start moving on here, and at the end of the day, if we can't get we don't have any progress. We've been working hard for 6 months, 12 months, maybe 18 months even, and nothing else seems to be helping. Opioids might be a really good option.
Do you think has that thinking changed since you were in medical school with the timing or the approach of it? Or has it 100%
changed?
Okay.
It's probably gone too far to one side, frankly. The pendulum always kind of swings. When I was a resident, there was one of the older attendings. We were writing a morphine script, and it was on a very high dose of morphine. And he's like, well, it's not working. We're going to increase it. And I was like, oh, okay. Well, so how do you know, like, what do you increase it to? Like, how much do you increase it to? And he's like, well, you just keep increasing until the patient gets a benefit. And I was like, whoa. that's being a lot of, and that was just the way it was back then. We have all the history now and the docuseries on Purdue Pharma and OxyContin and stuff, but that was sort of the thought process, and now it's really swung the other way. And we're really proud of the fact that actually, 80% of our patients that get a neuromodulator or a stimulator come off opioids within 6 months.
Wow.
With a corresponding decrease in pain, increase in function. And most patients that come in on opioids, they want to be off there. Like, is this all that I have? Is there something else I can do? And so we actually published a paper on that, and we're pretty proud of that fact.
So you mentioned spinal cord stimulators. When is the right time for a patient to seek that?
That gets to be farther down in the treatment algorithm also. And generally how we explain things to patients is we kind of go from, most conservative to more invasive. And that's going to be usually within the 3, I don't know if I mentioned this on our last talk, but just in case I hadn't, I always tell patients there's 5 things that can help pain. The MIPS, MIPSS. So medications is M, I is the injections, interventions, P is the physical, psychological therapy, S is surgery, and the last S is the stimulation. So most patients are going to be in the first 3 categories. 80% of patients are going to be meds, injections, and the therapies. And of those 3, it's going to be the therapies that usually are going to provide the most outcome. But as we work through these and we're not making any progress, or maybe we often see those patients that have maybe had spine surgery and have continued back pain, we do the injections, we're doing the therapy, things just aren't functioning the way they're supposed to, or they can't do what they need to do because of the pain that we're not really making an effect on, we say, neuromodulation or spinal cord stimulation or peripheral nerve stimulation might be a good option for you.
How has that changed in the past decade or so? When I was in school, they were sort of new and hot. How have they changed?
In terms of technology, they've changed several ways. First, in terms of being able to get it covered and make it an option for the patient. And then secondly, in terms of what the technology is now compared to what it was even 10 years ago. 10 years ago, the big thing was this high frequency stimulation with Nevro. It was like the talk of the whole pain community. And now we have dorsal root ganglion stimulation, and then we have low frequency. We got these closed loop stimulators now. And so I'm telling patients, I was like, if you think about your phone like 5 years ago, you can't even hardly use it anymore. And stimulators can be like that too in terms of advancements of battery function. They can upgrade now without having to take out and put a new battery in. So it's really advanced quite rapidly.
I had a patient when I first got into practice about 6 or 7 years ago that had a spinal cord stimulator, right? And he was in the process of, he was trying to decide whether to get a new one or kind of keep the one he had because he had lost, I guess, the controller of it. Mm-hmm. And I guess back then, there were only certain, he always told me that he had to get a certain, like an iPod Touch, and it had to be a certain model that supported the software to control this thing. And he was like telling me how he was going on eBay looking for this certain iPod Touch. So it's kind of funny how this software has changed quite a bit. How often does someone have to charge a stimulator?
It depends on the battery, and it depends on the usage. In general, it's anywhere between 2 and maybe 7 or 10 days. And and they actually have non-rechargeables too. So we actually put my partner and I had a patient that was 96. Wow. And we put one in her, and she was very spry. And literally a week later, my partner, Dr. Brodnax, he had a 99-year-old. I think that's the oldest he ever put in. And we're putting these in, and they're like, we're putting these in, and some of the staff and surgery center where we're putting in, they're like, well, they were new to pain management. Like, well, this is so old. Why are we doing this? It's like, listen, she just wants to be able to walk. Like, she's not having any cognitive issues. She is very active. She's active in all of her clubs. So we put those in. Those are great patients where you just put a non-rechargeable in. Like, the last thing you have to worry about is like having to charge it, and then you don't have it turned on and you're hurting. The non-rechargeable, it goes for, I think this FDA approved for like 5 years. Okay. Usage, a lot of these batteries. So yeah.
Yeah. I think it's all relative, right? If you got a 99-year-old and their goal is to play with their grandkids and walk without pain, and they don't have that, they want it. So they're probably willing to take the risk.
Yeah. Huge quality of life option for them.
Yeah. Yeah. Another aside that's kind of funny, I had a lady when I was in Kentucky that had been in a pretty significant car crash, and she had a spinal cord stimulator. And I remember setting goals for her, like her first visit. I was like, okay, you're here. You just had this pretty bad head-on-head collision. Your pain level's an 8. Let's get you to a 5 in 30 days. So I'm going over these goals with this patient. And I go, is there any other goals that you would like to hit? And she goes, I would like to take my spinal cord stimulator from the level it's set at, X, down to, I don't even remember, 14. And I was like, that is a very cool goal. I've never had a goal like that. And it's very, quantifiable. Most of the time it's subjective. Oh, I want to go on a pain scale. I want to do da-da-da-da. That was an interesting goal. And at the end of the 30 days, I was like, are we at the level 14 or whatever? And she was like, yeah, we're there. And I'm like, that's a really,
awesome.
Really cool
goal.
I
haven't heard of that one before, but just to speak to the importance of goals, we try to always have like the outcomes. And when patients are this bad where we're considering a neuromodulator, it's usually like, I would like to be able to try to sleep like 4 hours without waking up, or I want to be able to walk to the mailbox, or make my meal at the counter.
Yeah.
So when we do, and you do a trial first, you don't just put these in. You do a trial first, you go home with it. It's almost like a try before you buy, and you try for about a week or so, and you kind of measure those impacts. Like, what was it like sleeping? What was your activity levels like? What was your mood like? And if it comes back and the patient's like, this was, usually we like to see at least 50% improvement in all those factors. More is obviously better. then we discuss, is it worth putting this in under the skin permanently? And I always kind of compare it to sort of like a pacemaker for the spine, sort of.
Sure.
So we try it before we put those in.
I was always thought that it was more of like a TENS unit, the way it worked, and the patients actually felt it, but they don't, right?
They used to.
They used
and
to.
It used to be a big problem. Used to be a big problem. You put these in and they would work great for like 2 or 3 years, maybe 5 years. But then what would happen is a phenomenon called tachyphylaxis, which is basically a great example of that is rub your leg and keep rubbing your leg, and you rub it for 5 minutes. Pretty soon you don't notice that your leg is being rubbed.
Yeah.
Your brain just turns that part off because it's constant stimulation to that area. So your brain turns it off, and then that would happen in the spinal cord with these stimulators, and then patients wouldn't have relief anymore. And that can happen pretty quick. So now they have a lot of ones where you don't feel it. It's not tonic. It rotates programs, so it's constantly confusing the nervous system. So that tachyphylaxis or that tolerance to the stimulator cannot occur.
That's interesting because I have a similar therapy here that's called interferential. Are you familiar with interferential?
No.
It's a lot like, think TENS unit, right? More of a clinical grade, kind of on steroids. But it's funny, when I was setting this up and I was learning the protocols on it, it has something called a sweeping vector. And I'm like, it's got all these different numbers and angles. And I'm like, what does a sweeping vector do? It does just that, to reduce the tolerance. It takes that same interferential signal and it sweeps it back and forth to where the body cannot get used to it. Now, that's something that I'm doing in the office for 15 to 20 minutes. But even in that amount of time, 5 minutes in, patients are like, turn the sucker up. Another 5 minutes in, turn this thing up. So I can imagine how that would, obviously the advancements, they're getting to a point where they can almost trick the nervous system, which is awesome.
Yeah.
Epidurals, hot topic. It's interesting. I saw a post the other day, and it was like an epidural. I don't know if it was the packaging it comes in or whatever, but it says not FDA approved for spine use. Have you heard this? Have you seen this? I assume you have. What's the caveat on this? Why are people out there saying, "Oh, this is not approved for the spine"?
So, and what they're referring to there is usually the steroid that we inject. And that was a big thing that came out probably in maybe 2013. I think I was a fellow when it came out. And in fact, at that same time, there was a contamination in one of the facilities where there was a fungus that had had basically contaminated some of these Depo-Medrol vials. And patients, there was some fungal meningitis. There was a huge outbreak. I think some people even died from it. It was like a major national issue. And I was a fellow at the time, and patients, rightfully so, were super terrified of trying to get these epidurals and what the injection is. And if you look at FDA approval, it's a very arduous process. They usually approve a medication for maybe 1 or 2 conditions, and to get it approved for another condition is very challenging. And so if it's not FDA approved, doesn't mean it's not an approved therapy with doctor supervision. It just means that it hasn't gone through the rigors of FDA approval, and it's usually a financial constraint for a company to do that. Once they get it out on the market, they know that a lot of people can still utilize that.
What would you consider a success? First, somebody's getting an epidural for the first time. What would you consider success versus a failed epidural on trial 1?
And we talk about this with the patient too. We want to see, we have to measure pain scores. That's all we got. It's subjective. But we say, listen, we're looking in general for injections or anything we're doing interventionally on the spine. Or in the whole body, we just want to see usually at least a 50% decrease in pain. That seems to be successful where, you're 8 out of 10 of the pain, and if we can get you to 50%, that's 4 out of 10, that more than doubles your function theoretically, right? And for us, it seems to justify the risk-benefit ratio of doing that, which is very different than medications, for example. So we're looking at, decrease in pain, increase in function, and then the big thing with the steroids is duration. Are we getting at least 2 or 3 months out of it? We get a lot of results where maybe they only last 2 weeks, 3 weeks, and it goes back. People have different responses to the steroid. And so that's sort of our outcome factors. And that also can necessitate how frequently we can repeat the steroid injection without harming the body.
What does the first couple of days tell you about a steroid injection? I've had patients that obviously you and I are co-treating or, are doing both my therapy and an epidural. And normally I'll see them a couple days after, and a lot of times they're looking at me going, it didn't do anything. Should they be worried at 2, 3, 7 days if they feel no different?
No.
Okay.
No, the physiology of the steroid on the body, in general, it takes 3 to 10 days for that anti-inflammatory effect to fully kick in. Some patients feel relief on the first day. We always tell them it can take up to 2 weeks. So we'll schedule a follow-up with them in about 2 weeks. So we know that the steroid has fully run its course. The steroid stays in the body for about 2 weeks. And we know at that point the adrenal glands have kind of normalized, and we can see if the effect is lasting longer than that.
Yeah, it's something that's a hot topic in here a lot because they're like, man, that didn't work, and I just spent all this money, and I just da-da-da-da-da-da-da. And I normally have that same conversation with them. I'm like, you're not going to leave there 100%. Give it a week, give it 2 weeks, and then see where you're at. Is there a limit nowadays on how many patients can get per body region per year? Is that how that works?
There's a lot of probably confusion surrounding this, in my opinion, because there's a lot of patients say, I don't want a steroid because I don't want to have weight gain. I don't want to have a steroid because it weakens my bones. All true. I think it's important to tell the patients, and this is what we tell them, is, the dose is the cure and the dose is the poison.
Right.
So it all matters, like how frequently, how much is what's happening. So if you're on oral steroids chronically, it can be very problematic. We know very clearly defined outcomes that are negative on the body with chronic oral or even injectable steroid use. Very bad. Short term, it can be highly effective for treating the complex interplay of pain, which is an interaction between the immune system, the nervous system, the endocrine system. And we've been using this steroid for, over 50 years now in these injections. But, frequency for us, what I say is the steroid's in your body for about 2 weeks. And then your adrenal glands normalize within usually about 2 months. So for us, I say, and we should tell patients should know this as well, no more than probably 5, max 6 steroid exposures on a rolling 12-month basis. Because they'll come in, they'll see us, they see their orthopod, they get an injection, they go see rheumatology, they get an injection, and we're not tracking it. Like, we don't necessarily get all the rheumatology notes, for example.
Right.
Before you know it, they're getting overdosed on their steroid and they have a problem.
Spine, steroids, you're doing obviously the injectable. Oral versus other ways to dose this. Could an oral have a significant lasting effect, improvement-wise, on spine?
Yes, it can. Yeah. And we'll do that for patients. A classic example of that, somebody comes in with like a hot disc. We just had a guy, a fireman, come in, huge herniated disc, didn't have any imaging. We can't just take you back and put a needle in there without looking at the spine at least. So let's at least get you an oral steroid pack. It's going to be systemic, but some of that will circulate to where the pain is still going to be a systemic anti-inflammatory effect, which is what we're looking for.
Yeah.
And in that situations, we will give them a steroid pack.
Last time you were here, we talked, you brought up MRI, so I'll dive down that path.
Yeah, I love MRIs.
Last time you were here, we talked about how important MRIs are for what you do. They're important for what I do. Sometimes they don't match what people feel. You threw a stat out there, roughly 50% sometimes can miss this. Have you had any cases in your history that the MRI missed something pretty important?
Pretty important. In terms of a pain diagnosis, yes. Yeah, sure. We see that not infrequently. There'll be a patient that comes in and they're like, oh my gosh, I got pain going down my left arm, and what's going on? And we get the MRI, and again, there's like confusion during the visit. It'll be like, it's your right arm or your left arm? You got a small like 4 millimeter herniation there on the right. The left just shows some arthritis on the joints or something, and they'll be like, no, that's on the left. And so, all right, well, let's do the injection on the left and let's not do that. In terms of like a cancer diagnosis, something like that, usually we don't usually see anything. I haven't seen anything like that was missed on like an MRI that I'm aware of. But then I necessarily wouldn't know either because I would have missed it.
Sure.
So, yeah.
It's definitely a hot topic of MRIs and what they catch and what they don't. One thing that I've kind of been curious about on an MRI is, can you see inflammation on an MRI in terms of around the spine?
Yes, you can.
You can.
And that can be very helpful. So you can see swelling in certain areas of the spine or any part of the body on MRI. It's usually going to present as what they call edema or swelling in that area.
Yeah.
So we'll see that particularly, say, with like a vertebral compression fracture, where somebody fractures the bone in the front of their spine. We know there's an acute process there. There's actually swelling from that area, and we know that's a response to inflammation.
Yeah, totally. What's the biggest misconception that people have about epidurals and how you inject?
I think the biggest misconception about epidurals and just treating pain in general is that patients will come in and I'll be like, listen, it looks like you have some issues going down your leg here. These 2 levels seem to be the problem. And they'll hear, well, why don't I just have surgery? Why do you want to have surgery? I just want to fix it. And I'll say, well, we didn't have surgery for this, 100 years ago. And actually the steroid can actually fix the problem. A disc herniation, I tell them, like, if you don't have a leg weakness from your disc herniation or another sign that you need to have surgery right away, the disc herniation majority of the time will resorb back into the body, just like any other injury in your body. It just takes a long time because there's not a lot of blood flow going to that area. So we can get the inflammation down, get you back into rehab, and you don't necessarily have to have the surgery, know? And I always joke too, listen, if surgery worked for everybody, I wouldn't have a job. Because you just go have surgery and it'd be done, right? We'd be out of business,
right?
But we clearly know that surgery is indicated in some specific instances,
What's your opinion on discectomies?
I think discectomies are a great procedure for the right patient.
Do you think that, if someone has a really acute issue with a disc, that's traditionally when I have somebody going, I read about this thing online where they'll just trim the disc and it's in and out. What are you seeing? Are you seeing any long-term consequences or side effects with patients that have had discectomies?
I'm not seeing anything like that. The big thing with getting a discectomy is going to be you actually have an indication for surgery. So it's usually these are going to be patients where the herniation is so large and so big that it impacts the nerve so much that the nerve is starting to lose function and not being able to work. It's getting its blood supply cut off. You're having leg weakness. Maybe you can't feel your leg. Right. Maybe it's even compressing the spinal cord and you're having weakness down both legs. Send you to the surgeon, they cut it out, they cauterize it. Now, they can be reherniations in those same discs in the future for some patients. I don't think there's any data that I'm aware of. I might have talked to one of our neurosurgery colleagues, but that indicates like the incidence of that and which patients are at a higher risk for that. There is a limit on how many times you can do a discectomy on the same disc.
I was always under the impression from past research was that you could only have one on a disc, and then after that, it was pretty much going to be a fusion at that point. Is that not true?
I'm not sure if it's a fusion. That might have been the case before, but now, even the spine surgeons are doing a lot of minimally invasive stuff. That's good, and usually trying to avoid hardware where possible.
I love it.
Because we all know what happens when you get the hardware in there.
I had Dr. Nicholas Ferraro on here, a neurosurgeon, 2 months ago. And he was telling me about some of the nightmares with hardware where he's doing a revision surgery. He does a lot of revisions. And he was telling me that some of these, he used the word pod doctors. Does that mean anything to you?
It doesn't, but I actually watched that talk. And it was very interesting to learn from him.
Talking about how some of these, private groups have their own almost key and wrench for these hardware sets to where if you need them taken out, you're going to be cutting through metal. Good luck, which is insane to me.
It's unbelievable what's going on out there in some corners of our country, unfortunately. It's shocking. And we've seen some pretty wild things too. And I always tell patients, listen, some patients come in, they want the surgery. And I said, if you want the surgery, like you can find somebody to do the surgery. Trust me, there's plenty of options all around. And I even tell them when they see me, like, listen, get a second or third opinion. Talk to another pain doc. Talk to somebody else. You want to be hearing the same thing. A lot of people will go to the first, doc that they might see and say, you got to do this like huge thing. And it's like, well, how many car dealerships do you go to before you buy a car? You usually go to like 2 or 3 at least. And that's your car. Like, this is your body, So
right.
At least do 2 or 3 and make sure they're saying sort of the same thing. Now, if you're getting different opinions from each one, now take that information and go to a trusted source, whether it's your chiropractor, your PCP, your pain physician, and let's say, okay, here's the options. And in that case, they might all be a viable option.
I think that tends to be what confuses the vast majority of people is when they go and get 6 different opinions and they get 6 different answers. And sometimes that's justified in my opinion, because if you If you show up to my office with a herniated disc and you show up to your office with a herniated disc, we're going to have the same diagnosis, but 2 different treatments. Because we do different things, right?
Right.
And that's what makes the world go round.
Right.
But I think sometimes that confuses patients because they're thinking we might be having a different approach on this. That means that we're treating a different thing. So I always tell patients, I'm like, sometimes getting a second or third opinion is good, but sometimes getting 6 or 8 is going to make your head spin because you're just going to be going, this guy wants to do this. This guy wants to cut. This guy wants to do an injection. This guy wants to put me on a different medication. This guy wants to do decompression.
Right.
I don't know where to go. So I always, I think there's a sweet spot there of.
There probably is a sweet spot. Yeah. I've never told him to get 6 or 8. But I would say, that would be a little overwhelming. I'd say 2 or 3 is probably
2 or 3 is
good.
safe. You've been treating back pain for a long time. What is something you would never do?
Something I would never do for my back?
Just anything in general. Where do you see people hurt themselves? Where have you seen, hey, I've seen this so many times, I'm not going to do it.
I got one.
Okay.
Yeah. You triggered my memory. I, probably about 7 years ago, when our first child was born, I thought like, man, as she gets older, it'd be kind of cool to get into jujitsu. We haven't done jujitsu. I don't have any self-defense background, but it's something we can maybe do as she gets older. My cousin was doing it with his daughter. They're having a blast. He got in good shape. He got really strong, and I was like, yeah, jujitsu, that may be a fun one. And you're not like kicking and getting punched in the face necessarily, and getting your throat punched or whatever, like in Taekwondo. And I started seeing a few patients that do jujitsu, and these guys were probably mostly in their 50s, some guys in their 40s. They're coming in usually with like neck pain or, back pain. And we're getting their imaging, and their facet joints, little joints on the back of the spine, they're shot. They're like totally shot. And these guys are they're like tree trunks, and they're thick and everything's stiff. And I'm like, man, you guys are doing a number on your neck, on your necks. And so it probably, it's probably the extreme example. That's probably not the majority of people that do jujitsu, right? Don't have that, but you kind of end up looking at the window that you see, and you're like, I don't want to mess up my joints. I already know they're going to get arthritic with time. I don't want to like accelerate that. So I did kind of end up veering away from jujitsu and haven't really gone down that path since. Are
there any types of exercise or any certain movements that you see people repeatedly hurting themselves and showing up to your office with?
Interestingly, I see people that play an instrument a lot. One of my toughest patients when I first started practicing was this like wasn't symphony, but he was like a world-class tuba player in Chicago. And he had this big tuba on his neck. And he played it all the time. I can't remember if he was like in a band or an orchestra or something. And his joints on his neck were like totally shot from carrying this tuba around for like 30 years, You can see it with violinists, sometimes a superficial radial nerve.
I've had a violinist, and also because they're here, right?
Yeah, they're here, and they're cranking their neck, know. And I'm like going to the extremes. I'm like, all right, so I don't want my kids like, no tubas, right? No violin. Obviously, again, the dose is a cure. The dose is a poison. If you're playing 12 hours a day, you're going to have overuse injury from anything that you do in 12 hours a day. Whether you're sitting at a desk and typing on your computer, you're going to see the same thing. So if you're doing a half an hour a day, it should be fine.
Have you had any experience with treating, professional athletes decades after they played, seeing their imaging?
We've had a couple of those actually. Yeah.
Have you?
We recently took care of a football player. But he wasn't in super bad shape, actually. He mostly had mostly bad knees. And so I hadn't seen anything that was like terrifying in terms of.
I've had 2 ex-NFL players, and I'm talking they were 40 and the other guy was like 75. And their spines took a beating. I mean, I'll
tell you what, not to interrupt you, sorry.
You're good.
But I was going to say, it made me think of it. Who's got the worst pain, I feel like, of anybody, and they're probably the toughest people on the planet?
Who?
The bull riders.
Oh.
Bull riders. I've seen some bull riders.
Wow.
And those guys, they chew nails and spit bullets. And man, they spines and joints and they're tough too. And they're not, and there's not a, you can do some stuff for them, but their bodies just get wrecked on some of those bulls. The bull riders, they get a beating.
Well, you got to think about all of the whipping back and forth. And then they're getting thrown off.
They get thrown off.
And then, God forbid, they don't get stomped on.
Get landed on, multiple fractures, multiple broken bones. Don't even think twice about it. They'll go, ride the next night, And yeah, those guys are.
Takes a certain level of.
Yeah, it takes a certain type of human being to be able to ride them. You have a different level of toughness, in my opinion.
How good are you at looking at a person and knowing what their imaging is going to look like? So say you got a patient that comes into your office. They've got X pain. You haven't done a physical exam, but you've got a little bit of idea. You can look at them physically. Mm-hmm. How good are you at knowing MRI is going to look like this?
If they come in, it's usually going to be the radiculopathies, and those are kind of fun. You have somebody, gosh, that's my back, and it goes around my knee, and it just shoots down kind of into my shin. And we're like, okay, we're looking at L3, 4 maybe. Let's get the picture.
It's kind of fun, right?
Yeah, those ones are kind of fun, right?
Yeah.
And then you hit it. So the dermatomes are always, and they're fun to show, like the med students or our staff that's new to pain management, and you're like, oh, it's probably L3. Like, how did you know that? It's like, well, there's these dermatomes, And
what's funny is behind me here, I have a dermatome chart.
Oh, yes.
And sometimes I will actually get the patient in my first visit with them. I have them stand up, and I'll say, turn around. I want you to be the doctor today. And they're like, what? I'm coming here. I'm paying you. I'm like, what on here follows? And they're like, oh my gosh, it's C6. Holy cow, I go, look at that. And then normally we get the imaging later and they're like, holy cow, C6 has got some compression. And it's kind of fun. And I think it helps make the process a little bit more fun and involved for the patient versus like, all right, so you got a C6 herniation, here's what we're going to do. Like I'm big on that in my office. Like, let's make this fun. Let's make this somewhat lighthearted in a situation where people are like, oh my God, they hear the word disc and they think that they need to start getting their, get their bucket list ready. Sometimes there's disc herniation and they're like, I've heard about these online.
And to speak to that, and just even with, imaging and stuff too, we probably over image in general, and there's a whole variety of reasons for that. But the imaging and seeing these disc bulges and things, it can almost create problems sometimes for patients because they start to perseverate. Oh my God, doc, I got like 5 disc bulges, And it's like, those are normal. The over imaging can create that, because you're going to have normal variance. And
exactly.
So disc bulges can be and so I just try to tell patients that, but I think it's almost a problem that's not really addressed.
There is a lot of research out there that shows. I remember when I was in school, they were on this big push for pulling back on imaging because as chiropractors we X-ray a lot and we refer for a lot of MRIs, and you do the same, right? There was an article that was put out that was pretty prominent in, I think it was done by some chiropractors actually, and it was, hey, when you image and you show the patients it, not just read it to them, when you show it to them, it changes how they perceive. Oh, I've got damage, or they see the compression. I think I tend to think about that a little bit different, and it's big on how I educate patients. I don't look at it and go, this is damage, this is irreparable, this is so far gone. I tend to be on the other way around. Hey, this is bad, but I've seen worse, and we can help to fix this. We can help to create some space. So, but I do think that over imaging is a thing, but I think that when you use it tactfully and use it as a piece to change what you do, that's where it becomes a good tool. What is your opinion on imaging on that?
And that's exactly what I was going to say. The imaging, people get very caught up on, I need an MRI. Like, I want to see what's going on back there.
Yeah. And
recognizing that it is just a tool, and the contrast between patients' MRIs that don't have any pain and may look horrible, frankly, and other patients where their MRI doesn't look that bad and they have an incredible amount of pain.
Right.
We were just talking about this earlier with one of my other colleagues today. It's like, you'll see a 70-year-old and we're going to do, an injection. We have the X-ray going, and they have maybe just like a little bit of leg pain, and their imaging when we're doing the injection is like, wow, that looks like it's just super painful. They don't have that much pain though.
Yeah.
And then we got the 35-year-old coming in, pristine looking, X-ray, and is like 9 out of 10 pain. We're trying to get it managed, So the pictures really don't correlate with the pain. And there's a general trend of the lifespan, the morphology of the spine as you age that is normal variant. Like, for example, arthritis on the back joints, right? It's going to happen for everybody, and it may not cause pain. Just because you have arthritis on the back joints doesn't necessarily mean that you need to have something done about it.
Yeah.
What matters is if you're having pain from that or not.
We were talking before about, things that you wouldn't do. And you mentioned, I think you said, did you say jujitsu or what did you say?
Jiu-jitsu was the first one I thought of, yeah.
This reminds me, I had a 32-year-old marathon runner, unrelenting lower back pain. She was in the office once a week and it was like routine. And she just kind of accepted this as her fate. We get an MRI. Discs looked pretty good in her lower back. The facets, I think 3 of her 5 facets were severe arthritic. Severely arthritic at 32. Have you seen any marathon runners that have had this kind of repetitive compression on the lower back?
I have. In fact, just yesterday we had a patient that wasn't necessarily a marathon runner, but very physically active, Camp Gladiator. What's the other thing that they do where they lift all they do all the pull-ups and then they
CrossFit?
run. CrossFit, big CrossFitter, and very, very in good shape, and had very bad facet arthritis. She's young, she's early mid-30s, and she's pretty stressed out because she's already had a radiofrequency ablation back there and it lasted for a couple of years. And she's like, what's going to happen? This is going to fix it. It goes back to those patients that, do I need to have a surgery? I want this fixed, And I spoke to her. I said, the RFs aren't going to fix the arthritis, but what can happen is you can increase stability to that spine. If you think of the spine, like the lumbar spine is like a tree, basically, right? The lumbar spine where it curves is a tree trunk. And then as it goes up to the cervical spine, it kind of becomes the branches. And if you think about it, your neck is extremely mobile in that area and very high propensity for injury. Whereas down at the trunk, it's very strong and stable. But if you bend that trunk, you're going to have problems. And you can bend that if you don't have, good core musculature. And it's like, well, I walk a lot, I do all kinds of sit-ups and stuff like that. That's not what I'm talking about. Like talking and getting you in with the therapist that can help train those muscles to work the right way.
Right. I see this a lot as some people, they tend to think they're doing the right things in terms of exercise, and I'm doing 100 crunches a day and I'm doing da-da-da-da-da. What do you think is like a simple habit that someone can do at home if they've got, say, a lower back, generic axial lower back pain? What's a simple habit that they can do that will help them mitigate some of this?
One of the things I like to do, have you ever heard of Egoscue therapy?
I have not.
So I don't have any relationship to Pete Egoscue or anything like that, but he has some therapy exercises that I've found to be very effective for myself. I'll have a flare-up of back pain once in a while, just like everybody else. And he's got an inexpensive book. He's been around for like 40 years. But one of the things he advocates as a common cause of low back pain is overactivation of the psoas muscles, the big kind of strap muscles that come on the top of the lower back and go all the way inside of the hip.
Hip flexor, yeah.
Yeah, hip flexor, also known as a filet mignon. If you're a steak guy, that's what.
What's funny is I bring that up all the time with patients. Yeah. I can see them like kind of.
They're like, wait, what?
Grimace.
It's kind of weird. Yeah,
filet mignon. Yes.
Yeah. So overactivation that can pull in the spine. So one of the things in that book that he recommends is doing some wall sits with a normal curvature of the spine. Don't like flatten your back in. So just get a normal curvature and kind of activate the quadriceps muscles and see if you can turn off a little bit of that psoas muscle.
Interesting.
So probably half the time during the week, it might be a little bit TMI for the viewers, but I'll brush my teeth in the morning and I'll just go do my wall sit.
How long can you hold a wall sit, Doc?
Well, I try to do it for at least 30 seconds.
That's
If
good.
I can do a minute, that's great. And once in a while I'm doing it. My kids are going to the bathroom, they try doing it too. And of course, I'm trying to get them to get down low, but they keep putting their hands on their knees and stuff
Cheating
like
a little
that.
bit.
But yeah, try to do at least 30 seconds if you can. But starting anywhere to activate those quads because we kind of turn those off.
A lot of times the psoas will go into spasm when you have an acute episode of lower back pain. And then not to mention we sit as human beings extremely or way too much.
All the time.
Hip flexor is shortened and then you've got your body's natural response to grabbing onto that and just...
Would you say, are they saying that sitting is the new smoking?
Sitting is the new smoking. That's a fun... Everybody likes... That's a new term.
Yes.
What are you seeing... what are the... Compared to when you got out of school to now, how have diagnoses and just overall things that people deal with, how has that changed with work from home culture sedentary culture. How has things changed for you?
We're seeing, I think, a progression of some of those pains that can occur from is frankly disuse, a lot of disuse pain. We weren't designed to sit for 6, 8, 12 hours a day. And that's what we're doing.
Right.
And so we're starting to see these kind of manifest. And a lot of people find if they can tolerate it in an early stage with their pain, increasing your activity levels will improve the pain. So it's really kind of like a use it or lose it phenomenon. And you want to get ahead of it before it gets so bad, frankly, that you're coming into my office and you've had this wind up and build up of symptoms over, years to decades where you kind of just put off things going to get better, put off things going to get better. The early action on that, to combat that is what I see is making a big impact for people. I
think the number one thing that people say is, I wish I would have handled this 10 years ago when it started, or I wish I would have handled this after that car wreck and I left it alone. And it's the biggest thing that I advocate for with patients is the sooner you start, the easier it is to fix. If you got 20 years worth of lower back pain, it's 3 visits is not going to do anything. And probably 3 visits with you is probably going to be maybe taking the edge off. It's not going to be ridding 2 decades of back pain.
And on that note, I do try to tell patients that too when you first start. I say, listen, this is usually, we're kind of in a need it now society, and it's kind of because we have that option, right? So we've got to become accustomed to that. So I just say, listen, this has been building for years to probably decades, depending on your age. So give us like 6 to 12 months. Give us sometimes we hit pay dirt right away. We get really lucky. We find the pain right away. We can get it treated. Other times it's a little bit of a mystery, and we're trying to figure out where it's coming from. So, stay patient. With the process, trust the process. Our job is to guide you on your treatment path, with your pain.
Yeah. You mentioned that, we've talked a lot about spine in the past hour or so. In terms of extremities, what do you treat? Do you treat feet? Do you treat wrists? Do you treat shoulders? What do you treat?
Yeah, we treat head to toe pain. So trigeminal neuralgia, migraine headaches, lots, big joints, little joints. We have some patients that have chronic hand joint pain, foot joint pain. There's not a lot of good options from a surgical perspective. I'm not a hand surgeon or a foot surgeon, but a lot of times you just have to fuse it, So a lot of ones like, well, I don't know if I want to fuse it, right? Because then you're kind of stuck.
What's interesting is I feel like a decent amount of what walks into my office that's, hand or foot or ankle pain tends to be from an old injury and scar tissue and things like that. And I always think through my head, and sometimes I'll tell the patients this, but when you go in there and operate, you're creating more scar tissue for something that already might be a scar tissue-based pathology. What are your thoughts on that?
Yeah, the scar tissue is very challenging. I think scar tissue is a source of pain postoperatively for a lot of patients.
Yeah.
And I think there's a lot to it. And sometimes it's so extensive we can even see it on imaging. And we do have a couple procedures we can do to help with some of that scar tissue, but obviously surgery to cut scar tissue out is not the answer because you just create more of the problem. So patients that have easily formed keloids, for example, high propensity for scarring, generally really try and avoid surgery if you can, because you can develop scar tissue in that area that can create more pain that can be really challenging to combat.
There's a cool therapy that I do that's called Graston. Have you heard of it before?
I have heard of that.
It's a soft tissue.
So remind me, yeah.
It's a soft tissue mobility. A lot of people call it scraping. Stainless steel instrument. And the goal is to actually remodel and break down that scar tissue. Most of the time I'm using this in and around the spine. I'm using this on rotator cuff. I'm using this on plantar fasciitis, tendinopathies. It works really well. But one interesting caveat protocol of that is actually to reduce the keloid formation after a surgical procedure. And I was just working on a patient the other day that had Mohs surgery on her arm where she had some skin cancer removed. And every time she comes in, she's like, I could see, she's like, does that bother you? She's like, yeah, it bothers me. And I can't go out in the sun this year because I'm worried about the scar. And I'm like, okay, yeah, I get that. She goes, is there anything I can do to help get rid of this scar? And I'm like, I don't know if we get rid of it, but actually if you're in that sweet spot is 12 weeks. If you can get and do some of this Graston therapy on a scar, and this is strictly for, not strictly, but I would say 80% visual. The 20% is you're actually helping to mobilize some of this tissue, because if you felt a scar, obviously it's rigid, right? It's fibrotic tissue. So that's one cool therapy that you can do over that. And it takes, probably 4 to 6 to 12 visits of doing this. You'd strum it very, very lightly, kind of going in a figure 8 star pattern, but it actually helps break down some of the scar tissue, make it visually more appealing, and make it functionally better post-operative.
More
so
functional.
it's a fun thing.
Do you know, does that work like, is it just on the fascia? Does it work on the skin? Does it take stuff off kind of the bone? Or
So traditionally when I do this therapy, it's working on the fascia. Okay. So it's it's a myofascial release technique.
Gotcha.
You're going to be pushing harder to get down into that fascia, right? It's basically like a steamroller on concrete, right? If you've got all this blacktop that's hot and it's not flat, you take a steamroller over it, boom. And that's, if you take a cross section of fibrotic tissue, it's sort of very disorganized. Where if you look at something as a muscle tissue, the sarcomeres are very organized, right? They're very, looks like bricks almost. It's building blocks. So to answer your question, it is working on the skin. Traditionally, when I do it, not on scars, I'm doing it on old scar tissue. We're working deep into that. Think a deep tissue massage. For the scar formation, the pressure is 25%. When you do manual therapy on someone like that Grasson technique, you've probably seen some patients, they've got some petechia, they got some bruising.
Yeah.
Because somebody...
I've actually had it myself.
Yeah. And that's common. And you should have a little bit of that. That kind of tells you, it tells you where the areas are that kind of need it, basically. On a scar, the patient should be having no pain. It's a very much superficial. You're not trying to go deep down into the fascia for that. Okay. But go ahead.
I was going to say, on that same note, I've even been hearing and reading some stuff online about how not just the fascia, I think we could talk about the fascia being an actual pain generator. I think that's a very common pain generator.
Sure.
But even the skin adhering to the nerves and to the fascia itself as a separate pain generator.
Right.
I've been seeing some of that, and I came across an individual that has been treating that, and it's been really interesting. It was a whole area of pain management that I didn't even know about.
This was the story you told me a few months ago, right?
Yes, this was a story, and I've sent a couple patients over to this area when they usually have like a tented down scars, or what she sees a lot of is after like a joint surgery or a hand surgery, and they're braced. And it compresses the skin in the area. And all of a sudden, when they get out of that, the skin almost pulls and creates its own pain syndrome. And I've watched some of her videos. I've actually visited with her, and she'll move the skin off of the area, and she'll have them move, and she'll watch the skin lines, and she'll move it off, and she'll do it before and after, and they're hurting, and they don't. It's like I'm at a magic show. I mean, it is crazy.
That's
I've never
pretty
seen
awesome.
anything like it. Yeah, so it's a super interesting area. I think it's maybe an up-and-coming area a lot of people don't know about.
Is this lady a PT or?
She's actually occupational therapy.
Okay. So she's OT.
Yeah, occupational therapy, and she speaks all around the world on it and is very passionate about it. She works mostly with hand surgeons, actually. Yeah. And maybe CRPS, patients where the skin's all super tight and things like that. So that's something else that's recently come about that I think for certain patients might be valuable.
I think that there's a part of that in a lot of conditions, right? The scar tissue formation, but I also think that the fascia not having more tension than it needs to, or just more abuse than it needs to. And one of those conditions that I see a lot is plantar fasciitis. Yes. And it rarely walks into my door. It's normally 6 visits in, and the patient's on my table, and I could see them, they take their shoes off or whatever, and they're like, oh, what is it? My foot. It's the bottom of my foot. Put them face down on the table, grab that heel, boom. What's going on? So I've seen a lot of plantar fasciitis lately. I have a strong opinion that it's from footwear in the shoes we wear. How do you go about treating plantar fasciitis?
Plantar fasciitis, usually when they come to us, it's pretty debilitating. Gotcha. I mean, they can't even get up. They can't walk. It's super tight in the morning. We'll usually send them over to you guys to work, try to loosen up the tendon. We'll even sometimes do a PRP injection or like a steroid injection at the base of the tendon to try to loosen up. We got to be real kind of careful. We don't want to damage the insertion of that or it compromises the function. Right. Oftentimes those work, but I'm a big fan also of making sure that you get the footwear to help relieve that pressure and seeing a benefit from that.
So one of the biggest things that I've seen that's helped patients, and I made this analogy on my last podcast, and it is the foot has 26 bones in it and hundreds of tendons, ligaments, and muscles. And the foot is designed to be the support system of our whole body, right? It's designed to grip the ground, move, and our brain proprioceptively gets a lot of feedback from our foot. However, a lot of times the way we treat the foot in terms of footwear is if we treated our hand like this, I think you'd think I was crazy. So if you took your hand and you wrapped it really tight with tape, right? And then you put a cushion in there and you were like, I don't want the cushion's going to help a little bit. That's kind of how we treat the foot. A lot of people wear really narrow shoes and they tie them really, really tight. And they go, well, why isn't my foot supposed to be supported? It is, because we're not supposed to walk around on concrete all day long. But my argument is that, and from my experience, we wear shoes that are on the other end of the spectrum. They're too supported. So there's two factors that I look into when I'm looking at someone that has plantar fasciitis. One being, and I'll show you this, one being the width of the toe box.
Okay.
Right? So most shoes are going to have pretty narrow at the forefoot into the toe. So that's the first step, is a wide toe box. Have you ever looked at a footprint of an infant or a baby?
Not outside of the little one we do for like the ornament to give like the grandparents and stuff.
Next time you see one of those, look at it. The widest part of the foot is the toes. It's not the midfoot. What happens is when you wear shoes that narrow as you go down, you've seen people with those bunions and their toes are all, boom, they're jammed together. You ever seen a picture of LeBron James' foot? That's a weird question to ask another guy.
No, I haven't actually.
Look at that on Google.
Really?
Yeah.
Is it going to give me nightmares or?
So his big toe is over his second toe, and his pinky toe it looks like it comes to a triangle because these guys wear basketball shoes. Are you an NBA guy?
More 90s NBA guy. Not
Did you see what happened Sunday night in the Game 7 of the finals?
No, I didn't.
So I don't watch the NBA, but I saw this all over my feed. There has been so I got my shoe off here. There has been in the past 10 years, the NFL and NBA has seen a double occurrence of Achilles tendon rupture in sports. And I talked to you about why I think the wide toe box is important. There's a second thing that's important on these that I think has to do with that. And that's the fact that it is a zero drop, meaning the toe and the heel is at the same height. Most shoes that we wear have some sort of millimeter lift to them, right? If you think about a high heel, it's a pretty easy explanation. The heel is 2, 3, 4 inches, right? That would be a heel drop of 4 inches.
Right.
Most shoes, Hoka's, Adidas, Nikes, On Clouds, they're anywhere from 4 to 12 millimeters. It's nothing. Over time, it shortens all that tissue, right? So if you think about a lady in a high heel, the calf is shortened, the Achilles tendon is shortened, the plantar fascia is shortened. So why I like putting patients in a zero drop shoe. Now at the beginning, it's stretching all that. When they first put the shoe on, it's stretching all of that. So they're like, oh, I don't know if I like this. Once their foot gets used to that, it actually puts all of that structure at the right length. Going back to the NBA analogy, there's no evidence on this. I literally looked this up all Sunday night. There's no evidence that this is the case. But for me, physiologically, it makes sense. If you take all that tissue and you shorten it, and then you put an extreme load through that at its lengthened position, it's going to be compromised. Literally, the stats have doubled in professional sports in the past 10 years.
Really?
And what other reason that I can't think of any other reason of why this would happen? What is your thoughts on this?
Yeah, that's interesting. With a plantar fasciitis in particular, I'll usually recommend some kind of at least cork insole. I usually say like a Birkenstock or something that's pretty stable and solid. And that doesn't help everybody though. So I'd certainly be open to, I don't really know a lot of preventative measures for plantar fasciitis.
The thing about plantar fasciitis is not only is it shortened, but it's also weak. And that's where most patients go wrong, is they are stretching. That's half the equation. The other half of the equation is strengthening. That's another reason these shoes are good, is because they're wide and your foot is actually kind of sloppy in them a little bit. And you're like, these feel like my foot's moving around and I have to work. It's because they do, right?
Okay.
So going back to the analogy of the hand, if I tape my hand up, what's going to happen to all like your patient that was in the brace that had to go to the therapist? Put them in the brace, all of that tissue becomes sort of immobile and it's got adhesions and it doesn't work the way it should. That's how it is with our foot when we wear conventional footwear. It's not 1 year of wearing this. It's 3 decades of wearing this. And over time, this happens.
And I wonder what the impact even is with footwear on like back pain, for example.
Oh, 100%.
Because it all kind of leads up to that area. I can remember I got a new pair of shoes after my first daughter was born. And I don't know if it's because they were new insoles or what, but like I didn't have any like back pain for like a couple months.
Sure.
You know? And I don't know, and I probably should know more about this or read more into this, but like how does footwear impact not just the pain in the distal extremities, but also in the whole body?
Exactly.
You know?
And how a heel drop can actually influence lower back pain, I'm actually really familiar with this because I've done a lot of research on it. If you take this, and once you see somebody that has a massive like Nike Shock shoe, it's like, it'll ruin you forever. Because I was at a gas station 2 days ago and I watched this guy walk out with these huge, thick heeled shoes, not the toe, just the heel. And I'm thinking, this guy has to have foot pain. He has to, wearing those type of shoes. But how it influences back pain is when you take the foot and you elevate the heel ever so slightly, it puts a slight bend in the knee and it puts anterior pelvic tilt. And I don't know.
And what does that mean, I guess? I mean, just
anterior pelvic tilt?
Yeah.
So that is the classic, we call it lower cross syndrome or anterior pelvic tilt. So it's when your pelvis tips forward. Think about when you have a pregnant patient. I don't know how many pregnant patients you work on, but pregnant patient pelvis tips because you've got all that weight out front. You got some guy that's with a huge beer belly, right? So it tips where it's sort of, they're poking their butt out and they're pouching their stomach out.
Okay.
What that does is it compresses the facets and it actually closes down the intervertebral foramen because of that hyperlordosis. It's also very common with sitting a lot because if you think about the psoas and the hip flexor, shorten all day long, we go to stand up. What that does to the pelvis is it rotates it forward because it inserts inserts on the front of the hip there.
Gotcha. Okay.
Can pull the lumbar spine into hyperlordosis, which for a lot of people is going to cause facet compression and it's going to cause IVF stenosis, just real estate wise.
Right.
We're not even talking about the nerves and the soft tissue that's supposed to be in there. It's just going to cause compression on it via the structure.
Right.
That's one thing I'm passionate about. And, I had lunch with somebody today and they said, we obviously know that you treat spine. What else do you treat? And I said, I've somehow inadvertently become like a foot guy. And it's not because I wanted to. And it's not even, I kind of hate feet, to be honest with you. I've become numb to working on them. But I was like, I've sort of found this niche that I felt like a lot of patients were falling into where they'd been to the foot doctor, they had done XYZ, and they sort of were like in this cog, right? And they always were like, well, I'm just going to softer and softer and softer and softer shoes, which feels good temporarily because it's cushiony, but it actually makes the foot
progressively weaker
over time. So you take that shortened tissue and you progressively make it weaker, and that's where you get your plantar fasciitis. So stretching it is a good step. I'm on board with that. Strengthening is another step. So footwear is going to be big. Being barefoot as much as you can is going to be big. And there's a plethora of exercises you can do. One that I like is if you take a normal kitchen towel, throw it flat on the floor. Okay. Envision this. You've got your heel off of the kitchen towel and you have your toes barefoot on the kitchen towel and you're taking it and you're flexed, scrunching it underneath the arch of your foot. Okay. Quite literally doing this with your foot. That will help to strengthen all of those plantar fascia muscles on the bottom of the foot. Okay. Those two, with the change in footwear, I'll do a little bit of manual therapy on the bottom of the foot up to the Achilles tendon into the calf. 4 visits, they're looking at me saying 90%. That is 90% of people.
Wow. Just kind of waking them up almost, it sounds like.
100%.
Okay.
And I think if they did the footwear change alone, I think I could probably help 40% of patients without even putting my hands on them.
Wow.
It's that impactful.
That important. Yeah. And I feel like there's not a lot of education surrounding that. I mean, I don't know a lot about podiatry. We do see some patients from them in terms of like CRPS that happens after surgery and things like that. But I do feel like I often see when they come in, it's more insoles. It's, get a foam in there, get a different orthotic shoe and kind of support.
And I never once blame a doctor for what they do, because they were educated in a different place in a different time, and we have different resources, right? So I'm never gonna be like, this is ridiculous that they're doing this.
No, I'm uneducated on it.
Yeah, it's, you know what I mean? A lot of foot doctors are going to go with softer shoes that are, tie them tighter and let's put a big cushy insole in there. And I think it doesn't normally help. And like I said, this place is Texas Spine Center. This isn't Texas Foot Center by any means. But I've treated enough and I've seen enough where I'm like, it's just turned the light bulbs on. This is not something I learned in school.
Yeah.
This is something I've put together. And to me, it was the reason I dove into this sort of footwear is because when I was fresh out of school, I was wearing like some Adidas that I'd always worn. And after 12 hours of working on my feet, I was like, my feet hurt. Like my big toe hurt from kind of being jammed in. And I had a different pair of shoes that I worked out in that were sort of wider toe box. I had no idea what that meant, but just by the design, they were a little bit wider. And I started wearing those to work. And I'm like, I'm going to try to find a pair of shoes that's wider and has like room for my toes. And then that led me to a brand called Ultra. I've been recommending Ultra for years. These are a new different company called Flux that I just got into. Same concept, just different design, different company. But I'm excited to see how these do. But
I should probably get some of those because I'm not very good on the footwear side. I kind of just get the Berkeys, and I get like the Asics on sale, and I know I have wide feet, and Asics are notoriously narrow.
They are.
30% off. I'm like, all right, great, but there's probably some downstream consequences to because I have wide front feet too, so I'm gonna have to look into
two
those.
things you should never skimp on. One is a shoe. Another is a mattress.
I thought we were going to say pillow, but yeah, mattress too.
Pillows
I get asked about mattresses too and implications in back pain and neck pain, and I can't find any consistent data.
Most chiropractors are in love with Tempur-Pedic.
Okay.
I'm not privy to a brand. If I get somebody ask me, a lot of times I'm just going to tell them, I like medium to firm. I think the softer you go, the more problems people tend to have. With that being said, a lot of times that people go, my mattress stinks, is because it's too old and it's starting to break down and it's getting soft. I don't think that you need to spend $5,000 on a mattress. I don't think that you should spend $300 on a mattress. I think $1,000 to $2,000 is enough to get you a good mattress. I recommend medium to firm. In terms of pillows, I think I should have went into a pillow sales and not chiropractic, because I have patients every week that say, Doc, I'm on my 12th pillow this year. I'm like, really? Dang, these pillow companies are killing it. They're killing it. But yeah, in terms of pillows, do you have recommendations that you do?
I don't.
No?
It's really, I kind of just say whatever's comfortable, maybe some cervical support. You obviously don't want to have the neck, pushed forward. You want to kind of try and keep it somewhat.
It really depends on what kind of sleeper you are. So you've got three kinds of sleepers. You've got stomach sleepers, you've got side sleepers, and you got back sleepers. You can boil it down. People are a combination of the two, but that's really where it breaks down. Had a pediatric chiropractor on my podcast a few weeks ago, and we talked about how stomach sleeping has been demonized, especially by my profession, for the past God knows how long.
Really,
it just has been. And there was a lot of teaching on how it, increases some curves and lessens some curves, more old school, like positional chiropractors. I'm not against that. It's a whole different other topic. In terms of pillows, if you're a back sleeper, you're going to want something that's shorter in nature. And when I say a back sleeper, these recommendations change if you're a pancake flip-flopper sleeper, right? So if you go from side, back, stomach, it's going to be a different recommendation than someone that's exclusively side or exclusively back. Okay. If you're a back sleeper, and you do that primarily, most people are going to do well with some sort of mild contour, meaning something that you can put to support that cervical lordosis throughout the night. If you're a side sleeper, I tend to recommend something flatter and a little bit higher profile. Because if you think of it, you got to make up the space between your ear to your AC joint, your ear to your shoulder. Someone like you got broad shoulders, you're going to need a pretty big pillow. Okay. Now, if you got that pillow and you turn to your back, where are you?
Right.
you're here, right?
Yeah.
So if you flip from side to back, you're going to want something that's contour. And if you've ever seen a contour pillow, most of them, they have two different heights, right? So when you're on your side, you're going to want to be on that bigger contour mountain to make up this space.
Oh,
and if you go to your back, unfortunately, you actually have to flip that pillow, do a 180 with it so that little part can support the cervical lordosis.
Okay.
There's a fun brand called Cube. Have you heard of this?
Not cute.
So they took the conventional pillow that's a rectangle and they made it a cube because their argument is this is more cube shaped than it is rectangle shaped.
Oh, yeah.
So they make one that's like pretty big. I've never actually used it. I've had a few patients that like it.
Okay.
But, there's always the patients that, they're going on Amazon and they're buying the ones with the shoulder cut out and it's got 4 or 5 different dips in it.
I think it's a never ending kind of quest to find them.
I don't think that those are good. I think you either want to have a contour or you want to have a flat.
Okay.
I think it's
What are your thoughts
simple.
on like the 0G mattresses and are the bed frames, right? The legs lift up and then the heads lift up. And
I've got one. I think that you watch TV that way. I don't think you would sleep that way.
Yeah. We got one too, and I'll tell you what, I lift the legs up a little bit at night, and it seems to really help any soreness or stiffness I have in the morning.
That'll help. How do you sleep?
I like to sleep on my stomach. Usually I sleep on my side though.
So if you're a side sleeper, you're going to like that foot popped up a little bit. You're also going to like the head popped up a little bit. Just because human beings, as guys, we're a little bit less curvy. As females, you've got a wider pelvis, right? But physiologically, you're going to like a little bit of a foot lift and a little bit of and I'm talking a couple degrees.
Yeah, very small amount.
That will kind of help cradle you a little bit better.
Okay.
A lot of patients that I've treated that have those, they have them for actually like acid reflux. Because they can tip them up and get 20 degrees and really help with the acid reflux, which, that's a whole different story. But the 0G, my wife and I will use that like while we're watching TV, but I don't sleep that way because I can imagine if you turn to your side, that would be asking for
you get totally pretzeled.
A nightmare.
Well, and it creates a whole problem. I think if you sleep with your spouse or your significant other, they have the ones now too where you they both adjust on each side.
Is yours all one? We
did all one, and it might have been a mistake because I'm like 6'3" or something. My wife is like 5'2". And so, I'll lift up the feet and she's just kind of like got her toes up. She's like, what's the heck's going on here, or whatever. She's got to scoot up to get out of it or whatever. But you get both of them. And then you have to get like two single mattresses and you got to change the sheets and you got the barrier there. And it creates a whole nother making the bed thing becomes like a whole nother issue, right? So
when I bought a mattress, by the way, this is a hilarious story. When I bought the mattress we have right now, my wife was like 6 months pregnant, which do not shop for a mattress when your wife is 6 months pregnant. I'm telling you, it's a bad idea. We walk in this mattress firm on a Saturday morning, she's 6 months pregnant.
Yeah.
They lead us over to like the showroom piece. By the way, I've never bought a mattress from a mattress store like this. It felt like buying a used car.
Really?
Because all the financing things are on the wall. It's like 0% for 24 months. I'm like, I thought I was buying a mattress, not like a new SUV. Anyways.
Well, but you say the prices though, and it's like,
exactly.
Well, I'd say maybe $1,000 to $2,000. Like, could you imagine 15 years ago you're spending $2,000 on like a mattress, as a base?
So she gets in this bed, and it's it's right up front. It's in the showcase basically. She lays on this thing, and she's like, oh my God, Justin, you got to come try this. And I'm like, okay. So I lay in the thing, and I'm like, all right, honey, this is fine. She goes, I think I want this. I'm like, we've been here 30 seconds.
Wow.
So we walk around the store and the lady's like, picking a mattress is like getting a fragrance, like a cologne. She's like, you don't try like 15 of them or you're going to be quote unquote nose blind, right? You're going to be like, I don't know. They all smell the same. Mattresses, this lady was like the same way. If you try 15 of them, you're going to be like, yeah, this is comfortable at this point. I don't really know. So we try out like 3 of them. We go from expensive to $500, $300.
We went the wrong direction to start.
We went the wrong direction. We went. So I'm like, okay, honey. I was like, what's it going to be? Well, and she's got her in this 0G position. How good that is for breastfeeding. And I'm like, yeah, I could see that's cool. Mm-hmm. Whatever. So we get done. She's like, okay, with the adjustable frame and the mattress, you're looking at like $5,800. I'm like,
Wait, what?
Like, now I understand the 24-month same as cash.
Yeah.
Right? So we get this mattress to the house. We went through with it. I don't know why, but we went through.
Well, she's 6 months pregnant. It's just
6 months
like,
pregnant. I was like,
right.
You know what? This lady, I swear to you, this lady looked at me and she said, "Now, sir, this mattress will last you 20 years." I go, "Well, you signed to that?
Yeah.
20 years.
Yeah. Money back guarantee.
So we get this thing to the house, and night one, my wife's like up all night. She's like, "This is terrible." Get online. It takes 30 to 60 days to break a mattress in. I'm like,
oh, wow.
Okay, good. So I'm literally jumping on this thing like a kid on a trampoline to try to break it in, right? They won't let you return a mattress within 30 days because I think most people have that experience and they call and they go, "I want to know."
Okay.
59 days, she had 59 horrible nights of sleep. She's like, "This thing sucks."
Really?
I'm like, "What happened to you in the showroom?" She's
Yeah.
like, "I think it's different." Whatever.
Oh, interesting.
So I call the store and I go, "I want to exchange this for something." They're like, "No problem. You got like 180 days. So I go in our spare bedroom where our old bed is and I'm like reading them the code. She's like, "Now, sir, that mattress is only $1,200. It only has an 8-year guarantee. Are you sure?" I'm like, "I'm positive." So we get this, we exchange mattresses, get this new one that's like $1,000. And first night she's like, "Oh, this thing's great." I'm like, "Holy cow, I think we were bamboozled for like $6,000 on this mattress."
Yeah.
But they took it back, no questions asked. But that's why I kind of live in this space of like, I think you should spend at least like $700-800.
Yeah.
But I don't think you need to spend over $400.
Right. Something's over.
And I've had patients that get the side-by-side sleep number with the, it's got the lights that are sensitive when you wake up in the middle of the night and
temperature control,
and all that stuff, vibration, God knows what. I had a patient, I swear to you, he was a police officer in Kentucky. He told me he spent $12,500 on his mattress.
Jeez, man.
That's why I joke that I should have been in the mattress and pillow business.
Well, yeah, and then people will argue. They'll say, "Listen, you're going to spend a third of your life on this thing. Isn't it worth it?" And you're like, "Well, yeah."
Yeah.
I don't
get
know.
it, but I don't. I get it,
yeah,
but I don't.
I'm with you, man. I'm just like,
I
I can't find the right mattress. I can't recommend it to patients for pain on a consistent basis. A lot of it seems to be preference.
What's funny is Tempur-Pedic called me when I started this practice and they said, "Hey, most chiropractors, they do the pillows and the mattresses, they promote them and sell them." And I was new to practice. I'm like, "Tell me what you got." She goes, well, for the pillows, you can stock those in your office, which, by the way, I sell nothing here on purpose. So I'm like, not really interested in that. I'm like, product pusher guy. She's like, "Well, maybe then the mattresses will be the thing for you." And I'm like, "Okay, what's that look like?" She's like, "Well, we basically sell one mattress and like you would basically have them sign up and pay through you and we'd ship it to them." And I go, "People buy mattresses without laying on them?" She's like, "Oh, yeah. Like Tempur-Pedic, we're such a good brand. We got $180 or 180-day guarantee." I'm like, people buy mattresses without laying on them.
Wow.
That was amazing to me because I'm like, I don't have a mattress showroom in my front office here.
Right. Yeah, it's like,
come over that was amazing to me that she was like, "Yeah, people do that. People buy mattresses." And I guess that, people buy them off Amazon and they're $300, but I think that's different than spending $3,000 when you're like, "I've never laid on this thing. Is it going to be good?"
Right.
But,
then you got to, they have the return policy, but you got to deal with it. You got to get the darn mattress. My sister-in-law bought one of those purple ones a few years ago. It comes up and it's all kind of self-done and you just, and it pops open and you got all this thing.
It's like a can of biscuits.
You try for 3 months and it's like, who's taking this thing back? Like, you got to haul this thing out, it's a lot of work to take it back.
Because they're not like, they're sort of not, they're rigid, but they're not at the same time.
Yeah, and they have the different versions and stuff, and so she loves it. She's all into it, but I'm pretty basic and simple with that stuff.
Me too. And that story right there should tell you that stick with the middle of the grade. I don't think you need the Rolls Royce when it comes to mattresses.
Right.
Dr. Anderson, thank you for coming on version 2 of the podcast. I appreciate your time and your knowledge. Always a pleasure working with you. Always a pleasure having you on the show and bringing your knowledge.
Likewise. Thank you for having me. I had a lot of fun.
Of course.